Right, in this portion, I'm going to talk about management of different types of back pain. One of the big mistakes I see with therapists who don't know enough about the spine is they tend to treat everyone the same. With spinal impairments, there are different biases, and so these are a list of the biases. We're going to go into them more here as I lecture. But non-weight bearing, extension, flexion, hypermobility or instability, hypomobility, muscle and soft tissue injury, and postural dysfunction. For each of these biases, there's things you need to do in the acute phase, the subacute phase, and as it is progressing. I tend to consider the phases more on the protective phase initially, and then the subacute or controlled motion phase. And then when it gets into the chronic phase, I consider that the return to function. So not everybody continues to have pain 8, 10, 12 weeks later, but you do need to continue to work to control, to return them to function. Okay, someone with a non-weight bearing bias, they have pain typically that refers beyond just the low back. It can refer into the legs, sometimes as far as the feet. These individuals are worse when they perform flexion, and they're worse when they perform extension. They prefer to be in a non-weight bearing position. So things such as traction and other non-weight bearing positions, putting them in a pool, will make them better. So hopefully you can already start to figure out how we could treat somebody with a non-weight bearing bias. For individuals who have a non-weight bearing bias, the progression is to increase their tolerance to weight bearing. So you may start doing aquatic exercises, traction, exercises that are in a prone or supine position. But as they progress, you increase how much weight bearing they're having on their spine, and how much they can tolerate without an increase in pain. All right, extension bias. These are individuals who do better with extension exercises. They tend to be worse with spinal flexion. And the injury is often in that flexed posture that I talked about in the last podcast, where bending forward is putting too much pressure on the front, and you may get creep within that disc and actually alter the shape of the disc temporarily. So these individuals prefer to be extended. They're able to move that creep back into a normal position and decrease the stress that's being placed on the posterior structures. In some of these individuals, if that creep occurs in that posterior lateral or far lateral position, you may see a lateral shift. So they may actually be shifted to one side or the other. So in this picture here, this far right picture, this individual has pain all the way down his leg, and he is shifted, his shoulders are shifted to the right compared to his pelvis. Extension tests typically decrease or centralize the pain. So as they do extension, the pain that was maybe to the foot before has moved and only gone to the calf. That shows a sign of improvement. Diagnoses related to an extension bias include disc lesions, impaired posture, or that fluid stasis that we talked about. With impaired posture, though, realize they have to have impaired posture long enough to cause changes in the disc with either fluid stasis or some kind of disc lesion. Treatment for those who have an extension bias are extension exercises. We will go through many of these because they're all not straight sagittal plane, because a disc can protrude posterior laterally. Sometimes you have to move the force to a posterior lateral position to be able to centralize the pain. Once an individual is centralized, you need to work to stabilize the spine and get the muscles working appropriately. And then after several weeks of being stabilized, you can then start to slowly reintroduce flexion as long as the symptoms stay abolished. And just remember, the extension bias can be in the cervical spine or in the lumbar spine. All right, the next bias we're going to talk about is the flexion bias. These are individuals who do better with flexion exercises. they are more comfortable when they're flexed. You may hear a patient say, I can't walk very far unless I'm leaning on a grocery cart or a buggy and pushing it. Somebody who's pushing a buggy has to lean forward and they feel better in that position. They may say if I'm up and walking too long, which is in a slightly extended position, I have an increase in pain, but as soon as I sit down, the pain goes away. These people will have a peripheralization or pain that moves down the leg with extension tests, but they may have no symptoms seated, especially if they're seated with or reversal of their lordotic curve. Common diagnoses with this is spondylosis, stenosis. This could be either foraminal stenosis, where the vertebral foramen have gotten smaller, or it can be central canal stenosis, or a swollen facet joint. The reason patients feel better with swollen facet joints is because they're unable to close that facet joint down or extend their spine. Okay, the next bias we're going to talk about is those with hypermobility or some functional instability. So if you remember from the first talk this week, we talked about 3 ways to control the spine. One is through the inert substances that are there. So your bones, your ligaments, your discs, they provide stability. You also have the segmental and global stabilizers, and you have neuromuscular control. So if any of those are limited, you may start to develop some hypermobility. These individuals do best when taught stabilization exercises. So the goal is to control the spine and the laxity through your musculature. Training should be directed initially towards those deep segmental muscles, followed by the global muscles. This helping the patient be aware of the difference and the actions are necessary. Common diagnoses related to hypermobility can include spondylolysis, which is a fracturing of the vertebral area, spondylolisthesis, which is a sliding of one vertebrae on the other. You can have ligamentous laxity, and you can have trauma. So progression with these exercises, again, I talked about you want to do the deep segmental muscles first and then work towards the global musculature. Make sure you include functional tasks with proper spinal stabilization. A lot of PTs teach spinal stabilization exercises in a supine position. It's a great way to learn, but people need to be able to be stable in an upright and functional position. So make sure that you include functional tasks as the patient progresses and is able to maintain spinal stability. And the next bias is for those who have hypomobility. Some people may call it the mobilization and manipulation bias. These individuals, they have a limitation or a restriction in spinal movement, and it can be at one vertebral area or one joint, or it can be over several. These patients are treated with activities that help gain motion intersegmentally. So manipulation and mobilization are treatments that can be done. We are not going to learn that for the spine at this point. You will learn that in MSK. But there are things that you can do, that you know you can do, to gain range of motion and to gain movement. And so this can be passive stretch of the lumbar spine. It can be active range of motion exercises into their limitation. Muscular stretching may also be needed in both the cervical and lumbar spine. All right, next, these are for individuals that have muscle and soft tissue lesions. So we've talked about several times how to treat a soft tissue injury, and it would depend on the severity of the injury or the severity of the strain, how long it's been since the injury, and many of the things that Dr. Hartshorn talked about in his tissue healing lecture. So protecting the area is important. One thing that doesn't have really good support behind it is individuals who wear cervical collars or lumbar corsets. So cervical collars are usually reserved for those who have a severe whiplash injury and there may be some ligamentous laxity. In that instance, and when there is laxity within the cervical spine, a collar may be needed. But if they're using it only for muscular protection, you need to try to wean that when the patient is able to, because you don't want them to become dependent on a cervical collar and lose a lot of their muscle memory and muscle ability. Same thing goes for a lumbar support. It can be used following a serious injury. It can also be used post-surgically if you need to protect the injury site. But for something like a muscle strain, relative rest is better. Remember that bed rest is not something that should be done in somebody with a muscle strain. This has actually been shown to increase the problems someone's going to have with their spine. Progression of treatment with these is dependent on many of the things we talked about earlier, the severity of the injury, the location. So slowly progressing a patient back to full function is what you need. You need to protect the tissues initially while continuing to allow the patient to do as many daily tasks and functional activities as possible. Slowly increase the amount of work you're having the muscle do, and until they are able to get back to normal tasks. And the last impairment we're going to talk about is postural pain syndrome. We did a lot of discussion in lab or in class the other day talking about postural pain. These individuals tend to have pain after sitting for a long period of time. Depending on the severity, it may be 10 or 15 minutes or it may be several hours. They usually have faulty posture, so I say sitting a long period of time. I should say that maintaining any faulty posture for a long period of time will start to bring on their symptoms. Treatment of this we went through in our groups, and you have your Google Doc now that you can talk about how to treat any of these, any different postural pain syndrome. Now, even though there's several different biases that need to be treated differently, an individual will still have stages of recovery. Knowing the tissues that are involved and how severe the injury is will help you to be able to determine what to do in the acute, subacute, and chronic phase. So in the history, you're going to find out how long have these symptoms been going on. You're going to do your systems review. You're going to do your tested measures. You will be able to determine their stage of recovery at that point. There are some things I want to talk about with history taking. You need to make sure that you can rule out any serious conditions. You want to make sure they're having no signs of cancer. And again, I'm not sure you've had this yet, but signs of cancer would be weight loss for unknown reasons, night pain that is unchanged by moving position. So a lot of patients will have pain at night, but if they can say, well, I roll over, I get into a comfortable position, not a sign of cancer. So those are things to be asking a patient. Other red flags include somebody with upper motor neuron lesions, such as significant spasticity, some abnormal reflexes, any recent trauma where there hasn't been images taken to rule anything out. So say they fell from a high height, you don't know if they had a vertebral body fracture and they're having significant pain. That may be a referral out for imaging. And any pain that can't be explained mechanically. And like I said, especially pain that wakes up the individual at night, that is not typically a mechanical pain. If somebody's having neurological symptoms, you need to explore whether you feel it's coming from the spinal cord, the nerve root, or a peripheral nerve pattern. So knowing the difference between a C7 nerve root pattern and an ulnar nerve referral, or not referral pattern, or ulnar nerve pattern is important, because in an individual that has any neurological signs, you need to try to figure out where they're coming from. Right, somebody with an acute spinal impairment and they're in the protection phase, what should you be doing? So one is educate the patient. If they are a flexion bias, you need to educate them in how to decrease their acute symptoms through flexion. If they're a postural syndrome, you need to educate them on how to change postures so they don't have an increase in symptoms. So patient education is a huge part of that first day and should continue every day during the therapy session. Your goal is to decrease those acute symptoms. Any patient that's coming to you in pain, their main goal is to get out of pain. You're going to get inhibition of muscles, you're going to get faulty movement patterns when they hurt, and controlling those symptoms are important. Each bias has a different method for controlling those symptoms. Teach them awareness of their cervical and pelvic position. This will help maintain proper and safe postures. And begin working activation and control of stabilization muscles. Even if an individual has hypomobility and needs a manipulation at a certain area, a certain vertebral level, they still could probably benefit from stabilizing the spine. The stabilizers will protect your spine. You need to teach safe activities of daily living. We talked about that some in lab, about how to properly lift, how to properly take care of your daily tasks. And then for the protection phase, this is where you go into your treatments based on the biases. So extension, you do extension, flexion, you do flexion, etc. Our goal of the protection phase is to minimize, decrease, and if you can, abolish the symptoms. So within this protection phase, regardless if they have a cervical or a lumbar problem, stabilization may begin to help the patient. So I'm a fan of stabilization exercises as soon as they can tolerate them, all while continuing to do the appropriate treatment based on the bias. So working on those deep segmental muscles, progressing to the global muscles, are important as soon as the patient can tolerate them. All right, as the patient progresses into maybe the subacute phase, as we would call it, I prefer to call it the controlled motion phase when we're talking about the spine. This is when you have the patient begin to do more normal activities, but make sure they're aware of how to manage their pain and how to decrease their pain on their own. You want to engage them in activities that emphasize safe movements and posture. Teach them a home program, teach them any ergonomic adaptations they need at both the home and at work. Progress their awareness and control of spinal alignment as possible. You need to start to increase their mobility into the restricted areas, but only do so as long as the pain doesn't increase. Teach them neuromuscular reeducation, strengthening, and endurance. You can start to develop cardiopulmonary endurance too. There are many good studies that show that doing cardiovascular exercise is one of the main ways you can decrease pain in your spine. This is also a good time to teach any stress relief or relaxation techniques. Patients with chronic pain, or even I guess if they're subacute at this point, but patients with back pain or neck pain tend to have an increased tension. There's no times that you can totally relax your neck or your back, and so it can affect every aspect of their life. And going back to the cardiopulmonary endurance, you can always emphasize the bias when doing aerobic exercises. So, for example, riding a bike, holding onto the handlebars, you're going to be in a more flexed posture, and that would maybe be better for somebody with a flexion bias. Somebody with an extension bias may prefer walking on a treadmill. But if you are walking on a treadmill and you put it on a significant incline, the patient has to lean forward somewhat, and that flexes them. So knowing that and knowing whether that's appropriate for the bias you're trying to treat while doing cardiovascular exercises is important. All right, well, still in this controlled motion phase, it is okay to continue to work on pain modulation. This can be through grade 1 and 2 mobilizations, which you're going to learn in the future, but not in this class. Kinesthetic training, so making them more aware of their postures, giving them that feed forward so that they can develop segmental musculature, they can have active control of their spinal position, and they can correct their posture independently. Stretching and manipulation may be needed, especially in areas where there's secondary impairments of tight musculature. Working on muscular performance, you want to progressively increase the challenges for neuromuscular control, strength, and endurance, and all those stabilization muscles. These exercises need to include these activities that increase the control and strength of the musculature, help with spinal stabilization. And don't forget about cardiopulmonary conditioning. Very important in the overall health of an individual, especially someone who is having back pain. And then when the patient is continuing to progress, the pain has been under control, you want to progress them to their return to function. Emphasize spinal control, especially with any high intensity or repetitive activities. Make sure that practice active control in various transitional activities. You also want to increase mobility in restricted areas. So even if a patient wasn't a hypomobility bias, they're still going to possibly have limitations in both muscles, joints, fascia, and nerves. This is a good time to take care of those secondary impairments that may have led to some of the problems. Improving muscle strength, dynamic trunk and extremity strength, coordination, and endurance is important. Progress dynamic trunk and extremity resistance exercises, but you need to emphasize their functional goals. Remember what they want to be able to get back to doing and what they're going to do, and try to work towards that. Increase their cardiopulmonary endurance, and progress the intensity, of the aerobic exercises. So first, increase the time first, then the frequency, and then the intensity. Emphasize habitual use of techniques for stress relaxation and for postural correction. Make sure these motions and postures help relieve stress. Teach safe progression to higher level activities. So this is where patient education is very important. Sometimes you're only going to see a patient for a certain amount of visits, yet they're going to want to continue to progress. So before they are discharged from PT, make sure that you're educating them on how to progress properly. And then teach healthy exercise habits for self-maintenance. I often talk to patients on the very first day and say, what do you like to do for exercise? Because when we're done here, if you remain sedentary, you're going to be back to see me again in the future. So I want to get you on an exercise program that you're going to stick to. There's many free resources in every town. I know here in Cumberland County, there's Cumberland County Parks and Rec, and many of them have gyms that are free to Cumberland County residents. So knowing what's available for individuals who are unable to afford a gym membership is important. All right, for individuals, we're going to go through the biases again and talk about management. So managing the acute symptoms in somebody in a non-weight-bearing bias, you want to decrease the weight bearing on the joint, so traction and pull. For progression, progressively increase weight bearing for that individual. All right, for somebody with an extension bias, you need to know the effects of postural changes on that intervertebral disc pressure. So when they're sitting, the pressures are increased by 50%, and it doubles if they lean forward. So making sure the patient is either sitting with a very good posture or up and walking around is important. Bed rest. So when laying down, the pressure on the disc is decreased, but the nucleus of this between the vertebrae starts becoming imbibed with fluid, or it fills up. This, once they're standing, this is pushed into those intradiscal the intradiscal pressure increases, and it may push more and cause more increase in symptoms. So any bed rest given should be on very short intervals and be interspersed with standing and walking. I am not a fan of strict bed rest in anything less than a significant trauma where you have to allow things to heal. The effects of traction on this is that you are putting some tension on the annular fibers in the posterior longitudinal ligament and allowing it to become taut. This may help the disc to move back into a proper position. If traction does relieve the symptoms of a disc problem, the application should be short. If you can control these symptoms through movement, that is always best, because then the patient can control it on their own. Isometric and dynamic exercises. Begin with isometric core exercises and progress to more dynamic, but don't do a lot of early core exercises if their symptoms are significant, because that can increase some of the intradiscal pressure. So once the symptoms have decreased, then you can begin those core exercises moving from isometric to more dynamic, but make sure the symptoms are starting to be under control. And muscle guarding is something that's a reflexive occurrence. You can use modalities to help decrease that in that acute phase. Right, indications for using an extension bias is when a patient does better with extension and worse with flexion. These patients typically have pain that go at least into their buttock, if not down their leg, and occasionally into their foot. Precautions would include any instability, especially if you're going to do end range extension exercises. Contraindications, so you should avoid doing repeated extension exercises when that increases the pain, or when no position or movement will decrease the pain. So if a patient has increased or same pain with both flexion, extension, side gliding, extension may not be the best treatment for them. Also, when you have any cauda equina syndrome, so such as saddle anesthesia or bladder weakness or loss of bladder control. If a patient is in such extreme pain that they hold their body rigidly, they're not going to be able to relax to get the lumbar extension. So you should avoid doing extension exercises in that phase. These are all interventions that can be used in an extension bias. So extension exercises, prone press-ups, any kind of extension mobilization or manipulation. A lateral shift correction, which we will go through in lab. Patient education, so teaching them how to stay out of that flexed posture. Lumbar traction can be used. We talked about joint manipulation, and then stabilization once they are making progress. All right, I'm going to stop that podcast. Next, we're going to talk about surgeries, and I'll do that in the next podcast. Hey, this is Dr. Lenicky, and I am going to do a podcast here on parts of Chapter 15 and spinal pathologies. All right, the first we want to talk about is pathology of the intervertebral disc. So a herniation is where the disc material has gone beyond the normal limits of where the intervertebral disc should be. And there are three types of herniations. One is a protrusion. So this is where the herniation has displaced, but the disc material remains within the disc. An extrusion is another type of disc herniation where the disc material moves beyond the posterior longitudinal ligament or beyond the intervertebral disc space. And then sequestration is when the disc material has moved away from the disc. So this picture is showing different varying amounts of disc breakdown. So the first one is a breakdown of the fibrous layers, and the annulus has some displacement, but it's still within the disc material. In picture B, there are some fissures that you may see that are starting to break, and the material is bulging out against the outer area of the annulus. So this would be considered a disc protrusion. Where in C there is disc material that is starting to move through the disc, but it still is in contact with the disc. So this is a extrusion. Where in D there's sequestration. So the nuclear material has moved beyond the annulus, and it is actually a separate piece of material. All right, so there can be breakdown of the disc, and that's usually what's happening. This occurs with a lot of axial overload or a lot of pressure through the spine. You'll see this with around here a lot with those who have been on airborne status and had a lot of airborne operations where they've had repeated falls or repeated jump landings. Your discs also break down with age. There can be degenerative changes, especially with repeated forward movements, and these forward movements are what causes the disc to move posteriorly. So if we go back to the previous slide, you see that the typical disc here is moving posteriorly and sometimes posterior laterally because that is a weaker area of the disc. Also, with disc breakdown and as the disc loses height, you're going to have an increased mobility in that segment. So the disc is not taking as much space and you may have more movement within the vertebral column. This movement, though, isn't necessarily good. You will have greater shear forces, more forward and backward translation, and that leads to segmental instability. Alright, so we're going to talk about tissue fluid stasis. So during repeated flexion movements or even sustained flexion movements, there's compression on the anterior aspect of that vertebral disc. Over time, creep occurs where the fluid moves towards the posterior aspect of the disc and ligamentous stretch may occur. This creates a disc that is no longer completely flat. It's almost in a wedge or a triangular position. And that's why when many people have sustained flexion movements, they go to stand up, it's more difficult because that disc is now thicker in the back and thinner in the front. And it is a factor of creep. It can return, and this is one of the main reasons why repeated extension can benefit patients even when they don't have a true disc bulge. Many people don't understand the difference, and so they think as soon as they're doing repeated extension exercises, they're automatically treating a disc bulge. It may just be that they're treating a disc that has had a lot of creep and has changed its shape. Right, when it comes to signs and symptoms of either disc lesions or this fluid stasis movement, the typical symptom you're going to see initially is pain. But you need to be careful. Only about one-third, the outer one-third of the annulus is innervated. So until the problem is significant, they may not have pain. Other signs are neurological signs. These neurological signs can be true nerve or spinal cord pressure if the disc bulge is that significant, but it can also be referred pain. So referred pain can occur from stimuli of the spinal muscles, the interspinous ligaments, the disc, the facet joints. So there may not be true nerve root pressure, but there is going to be referred pain. So symptoms of a disc lesion can be varied, and mainly because the disc can protrude in many different directions. Posterior and posterior lateral are definitely the most common. When you get a posterior lateral bulge, it may cause some spinal cord symptoms, but typically a posterior lateral is going to hit more on those nerve roots, where a direct posterior may cause more spinal cord issues. Some of the spinal cord issues you need to be concerned about is loss of bladder control or anesthesia in the saddle area. If that is the case and patients are having bladder control problems or saddle anesthesia, that's an emergent referral. So you often send them to the emergency room with signs of a cauda equina syndrome. If there is an anterior bulge, it's pushing only on the anterior longitudinal ligament. That can result in back pain, but there's no neurological areas. So the spinal cord is not there, the nerve roots are not there, so there's not going to create the neurological signs. And often with disc lesions or those who have fluid stasis changes, their symptoms may shift. So at one point, if they have increased the fluid shift or increased the pressure anteriorly so that the shift moves more posteriorly, their symptoms are going to be greater. To where if they get postures that are either putting an even amount of pressure on the disc or even extending the spine, that can shift the fluid anteriorly and lessen the symptoms. And if the contents of the disc material are extruded and sequestered into the dural sac or to anywhere within the neural canal, they can irritate the dural sac, the nerve roots, and the nerve root sleeves. This can cause not necessarily pressure that's mechanical related, meaning that movement, inflection, or extension will change the pain. They need to be treated with anti-inflammatories, and medical intervention may be needed if this sequestration is causing symptoms. So in other words, if disc material is into that neural canal, surgery may need to occur so that they can go in and remove this material. Alright, individuals who have intervertebral disc or the fluid stasis issues with a disc typically have an onset of pain that refers down either the arm for the cervical spine, sometimes the scapula for the cervical spine, or down the leg. This phenomenon, we're going to talk about this more later, is peripheralization. So when the pain moves from a central position to a peripheral position, so in other words, if they have pain in their butt and then it goes to their foot, that's called peripheralization. And as the pain is able to move back closer to the back, that's centralization. A problem that goes to the distal extremity, so here on the fifth picture on the leg, or on the sixth picture of the arm where the pain goes all the way to the hand, that's a bigger problem than someone who just has some low back pain or pain into the buttock and thigh, or here pain into the upper trap area or upper trap and scapula. Typical people who have disc problems are usually between the ages of 20 and 55, with most people being in their 30s and 40s. Unless it's a trauma, typically it doesn't occur outside of those age ranges. For both the cervical and the lumbar spine, prolonged flexion will exacerbate the symptoms of a disc bulge. So the typical patient that comes in with a disc problem, they're usually they're not going to be comfortable sitting. They prefer to stand and walk. These are the patients that if you ask them, what are you doing when the pain comes on? They'll say, I wasn't doing anything. And if you dig further, you'll find they were sitting on the couch or sitting at work, usually in a seated position where they have that increase in lumbar or decrease in lumbar lordosis, so sometimes even moving into a kyphotic posture that's putting pressure on the anterior part of that disc and pushing it backwards. Initially, backward bending may be limited, because remember that fluid stasis has changed where the fluid is now moved. There's more in the posterior aspect and the disc is wedged. Once they're up, if you can return the creep back to a normal position, they enjoy being in an extended position. If you're assessing these individuals and you have them do trunk flexion, either in a standing position or in a supine position, such as double kneaded chest, that tends to peripheralize their symptoms. Okay, so what's the relationship between this disc and the wear and tear in the disc and the facet joints? So initially with disc degeneration, there's an increased slack and an increase of mobility and translation of the spinal segment. So this causes the facet joints to have more strain on them. They may be irritated or swollen. And as we know, in irritated, painful, swollen joints, muscle control decreases, so that the muscles that will help to stabilize the spine are not going to be working as well because they're painful. So with repeated irritation, with repeated problems to the lumbar spine, you will get bony changes. This can be called spondylosis in some patients, osteoarthritis, or degenerative joint disease. It's all related. You may see osteophyte formation or bone spur formation along the facets. You may get some bony formation where the disc and the vertebrae meet. And some of these discs may narrow the foramen where the nerves pass, or even the foramen where the spinal cord is. And as we've mentioned somewhat before, the related things that can occur with intervertebral disc and facet joint pathology is you will get some segmental or clinical instability. You also get stenosis, which is narrowing of those canals. You may have neurological symptoms, which is a radiculopathy down the leg. And you will also have some dysfunctions such as muscle splinting, pain, This may further restrict the movement. Okay, now we're going to talk about the facet joints, or the zygapophyseal joints. Facet is easier to say, so we're going to stick with facet joint. So some common pathologies that you may see with facet joints. One is a facet joint sprain or a joint capsule injury. This is much more common if there's a trauma, a fall, or a motor vehicle accident. You can see the osteoarthritis, spondylosis, and degenerative joint disease. This is when you're getting bone spurs, wear and tear of those joints. Also, there is a relationship between facet joint problems and rheumatoid arthritis. In individuals who have rheumatoid arthritis, they're more likely to get some degeneration throughout especially the cervical spine. It's very common to see atlantoaxial subluxation, so be very careful. You would not do spinal mobilizations or manipulations to individuals who have rheumatoid arthritis. They also tend to get C4-5 and C5-6 dislocations from the wear and tear. Individuals who have a disease called ankylosing spondylitis have chronic inflammation of the ligaments around the lumbar spine. In about 20% of individuals with ankylosing spondylitis, they have fusion in many of their bones, especially at the spine. It's relatively common, so between 1 and 3 people per 1,000 get it, and you're usually diagnosed relatively early in your mid-20s. So if you have a 60-year-old coming in who's never had this diagnosis, this is not the first thing you should be thinking of. In the case of, if they have hypomobility, their hypomobility is probably not from ankylosing spondylitis. But if you get someone in their 20s and they have significant loss of motion, you need to consider this. If you are seeing a patient and you suspect ankylosing spondylitis, some of the symptoms that have been indicative of diagnosis is that they have stiffness for greater than 30 minutes in their back. Their pain is improved with movement such as exercise, but their pain is worse with rest. Also, they will have pain that wakes them up in the second half of the night, and they may have buttock pain that alternates from one side to the other. And the last facet joint pathology we're going to discuss is facet joint impingement. So you can get tiny parts of the facet joint capsule entrapped or impinged. And usually this occurs when you're doing a forward flexed and rotated movement. So you've fully opened up that facet joint, and upon returning you get an entrapment of the joint capsule. Symptoms of this include loss of specific movement. So in other words, if the right side, and let's say in the cervical spine, if the right facet joint gets impinged when it is open, you're going to have difficulty extending the neck, side bending the neck to the right, and rotating the neck to the right, which are all activities that close down that facet joint. But there's something impinged in there and it's not wanting to close. Right, now we're going to talk about pathologies of that vertebrae. So one is a compression fracture, and usually this occurs secondary to osteoporosis. We've talked about osteoporosis several times, but these usually occur in the 6th or 7th decade. The pain will be referred to the low back. It may even refer into the abdominal region. There may or may not be any lower extremity radiculopathy. These patients usually present with an increase in kyphosis. There's a thing called a dowager's hump, which is that anterior kyphotic posture that many individuals with prolonged poor posture tend to develop. Cervical interventions such as something called a vertebroplasty may be indicated in severe cases. So they now do surgeries where they stick a needle in and fill up the vertebrae with a substance to create a height in that disc and to make it more stable. And some of the risk factors for a spinal fracture include being over 50, being female, having a major trauma, so being in a car wreck, falling from a higher level, having pain and tenderness, and a painful injury. If you have more than 3 of the following, you have a pretty high rate. You have at least about a 50% probability of having a compression fracture. And the final vertebral pathology we're going to talk about is Scheuermann's disease. This is a disease that usually occurs in younger individuals, so around the teens. It is a congenital and degenerative weakening of the vertebral end plates, and it usually causes an increase in thoracic kyphosis. So the normal curve is here. Somebody with Scheuermann's, they have a significant curve. There's been no pathology, so many physicians will diagnose it as growing pains, especially until they start to see changes. So anytime you're treating a younger individual who's starting to have back pain for unknown etiology or unknown reasons, at least consider Scheuermann's disease. And now to talk about different pathologies related to muscle and soft tissue. So just like every other muscle, you can strain it. You can get wear and tear and overuse. Think of all the times you've strained a muscle trying to do a new activity. So the symptoms of a trauma from a strain or tear is pain. You may get localized swelling. You'll have tenderness over the muscle that's painful. You may also get protective muscle guarding. This, is your body's reaction to any kind of stress. If it's a ligamentous pain, you'll have an increase in pain if that ligament is stressed. All right, common sites of lumbar strain, usually along the iliac crest. So think of muscles such as the thoracolumbar fascia, the quadratus lumborum, your erector spinae, your iliolumbar ligaments. And so all of these go along that lumbar spine. Injury can occur with falls or with repeated loading, so too heavy of a lift. In the cervical spine, you can get flexion or extension injuries. With extension injuries, you will have an increase in cervical extension. And this can stretch the anterior structures such as the longus colli, the suprahyoid, the infrahyoid, but it also can put stress on those posterior structures as the facet joints start to close. With flexion injuries, it's a rapid acceleration into flexion, and usually the only thing, you have enough mobility that your chin hitting your sternum may be the only thing that stops it. And so this, you will get the posterior cervical muscles, ligaments, and fascia stretched, and you may get pain from that. All right, that's all for this podcast. I may either podcast more or lecture more on this chapter. See you soon.